lectures on associated topics to orthodontic surgery. The first one being orthodontic surgery in the cleft patient. And this is certainly appropriate because later today we're going to be doing a virtual surgical plan on a cleft orthodontic case. And the surgical demonstration tomorrow at Dr. Dental College Hospital is on a cleft orthodontic patient. So, things to think about with individuals who've had cleft lip and especially cleft palate repair. You think about maxillary growth, and it's in 3 dimensions. But what have you done when you've repaired a lip, and especially the cleft palate? You've introduced scar formation in the healing cleft repair. So you have soft tissue scarring, which is oftentimes restricting the growth of the maxilla in the cleft patient in all 3 dimensions. So oftentimes these patients are hypoplastic in all 3 dimensions of the maxilla, and potentially what I call a pseudo class 3, meaning that they may have a underbite, but their mandible is in a normal position as the maxilla that's hypoplastic. In the case that we're going to be operating on tomorrow and VSP tonight, interestingly, he's not only hypoplastic in the maxilla from the cleft, but he's also prognathic in the mandible surgery. Again, as I mentioned in my prior talk, you want to evaluate the patient clinically and radiologically. You want to get a set of models, see how everything fits, and you want to make a determination, okay, what do I need to do? Is this a single jaw procedure? Is this just a maxillary advancement? Or would the patient benefit from a 2-jaw procedure? You want to take a good look at intraorally at scarring. We had mentioned before, one of the issues with scarring is, can I mobilize that maxilla far enough, or do I have to distract it? Again, as I mentioned, you have to look in all 3 dimensions at the maxilla. Lateral staff is usually the best way to start, getting models to look at the transverse, and as well as a clinical evaluation for the vertical position. Are there other malocclusions associated? Is there an open bite? Is the patient prognathic, etc.? And then you have to figure out, okay, my maxilla needs to be moved. Do I need to move my mandible as well? We talked about model surgery and virtual surgical planning, and we'll get into this later today. But talking about techniques. So when you're doing a Lefort osteotomy on a cleft orthodontic case, a lot of it comes down to the alveolar clefted bone graft site, if the bone graft is taken versus not. And one of the things that we think about is, okay, let's see, is that bone graft that was done hopefully by age 10, what shape is it in? If the bone graft has taken well and is contiguous, then it's basically the same as doing a non-clefted Lefort osteotomy. It's your standard procedure. Oftentimes in the cleft patients, you may want to consider doing a higher level Lefort osteotomy because they have some midface deficiency as well. And you do, as Dr. Lee described before, standard Lefort osteotomy all the way to the posterior wall of the maxilla. Then again, you have your straightforward osteotomes or nasal osteotomes, and you take your pterygoid plate osteotome, break the pterygoid plates, and then you gently down fracture. And again, this is in the case of a cleft orthodontic case where the bone grafts have filled adequately, and it's a standard Lefort osteotomy procedure. Then, of course, you have to mobilize the maxilla, and you have a occlusal wafer splint that'll put the maxilla into its pre-surgery determined position, and then you go ahead and rigidly fix it. Now, if you have a Lefort osteotomy, if you have a patient who needs a Lefort osteotomy, but their alveolar cleft bone graft in a unilateral situation has not taken, or it doesn't have a bone graft, then there's some modifications you have to think about. This is now a multi-piece Lefort osteotomy. You have to look at the soft tissue. Are there strictures? Are there fistulas, etc. That you have to deal with? And what are you going to do with that gap? Are you going to bone graft it simultaneously, or are you going to close it? So those are things you have to decide. So it's a standard vestibular osteotomy, with the exception of if you have that alveolar cleft, there you have to basically dissect around the alveolar cleft. And then you have to make a decision, do I want to bone graft that alveolar cleft simultaneously, or do I want to close that dental gap? Typically, I will try to close it, and I usually design a split where I can bring the dental segments together. It still leaves a bony defect superiorly that I may have to bone graft. So as you can see, you have an untreated or failed alveolar cleft. And what we've done is a standard Lefort osteotomy. We brought the segments together, and then we bone grafted the defect. And then you close. Closure is a little more complicated.
The lens extend করা যায় up to 48 megapixel.
Bilateral cleft Lefort osteotomies are much more challenging, I think. You have to leave that premaxilla anteriorly. The incisions have to be away from that, because that's where your blood supply is to that premaxilla. So you have to actually go around palatally to that premaxilla with your incision design. And you now have basically a multi-piece maxilla that you have to decide, am I bone grafting these segments, or am I bringing the segments together dentally? So again, as you can see from this design, for the incision, we've left the maxillary labial gingiva intact, and our incision design went palatally behind that premaxilla. And we've down fractured those lateral segments as well, and freed them up. And if you need to mobilize that premaxilla, you're going to do it from a palatal approach by breaking the bone. And then typically we'll have our splint design such that it'll bring those segments densely together. And again, you may have to do some bone grafting for any bony defects, and then you rigidly fix it. And then you close. So just a couple cases I wanted to show you. A 21-year-old with a unilateral cleft born with unilateral cleft of the palate had a successful alveolar cleft bone graft. So you can see that he has a well-healed alveolar cleft bone graft, and we're treating this like a normal orthognathic procedure. Edge-to-edge occlusion. He's still missing his right lateral incisor, and the orthodontist is maintaining that space so we can eventually put a dental implant in there. So what we ended up doing was Lefort osteotomy, maxillary advancement. I also planned, just in case, a mandibular procedure in case I was having difficulty mobilizing that maxilla. It was a 5mm advancement, and I was a little concerned with the scarring. I would be able
Thank you very much.
as far forward, so I planned just in case
তোমার আবার ডেন্টাল কলেজে দেখছি না নাকি তোমার প্লেসমেন্ট করেছে
I also put an implant.
মানে আমাদের এটাতে যেটা বঙ্গবন্ধুর আমাদের এখানে যেটা
Dental implant and cheek implant. Well, I was able to do this with just a maxillary advancement. And so this is lateral septal postoperatively. This is his 3D CT scan. You can see the dental implant here. 1 month post. Swollen. Usually that's good over here.
না এই যে ডাইরেক্ট
And this is him debanded. 8 months post surgery.
ও তো কথা বিশ্বাস করো না
And with his
না কি করবো তোমার তো প্রমাণ দেওয়া ছাড়া উপায় নেই স্যার এই
Another
টেকনোলজিটা এক
case
সপ্তাহ
was a
একটু
little more
বলবেন স্যার
challenging. This is
পরে বললি আমার লেকচার হচ্ছে তো
again with a unilateral cleft palate who had a severe, he was class 3, but also had a fairly significant maxillary cant that we had to try to deal with. So he ended up having a Lefort osteotomy, but also a lower jaw osteotomy, just so that we could address the maxillary cant as well as get the occlusion into its ideal position. So this is our virtual surgical planning that we did. The Lefort osteotomy combined with vertical ramus osteotomies. This is the post-operative CT scan. Now, because we have to address the cant, so we have to bring the right maxilla down, that's a significant gap, so we did some interpositional bone grafting into that gap, add stability, good for healing as well. And this is his post-operative occlusion, immediately post-op, and this is him debanded. And this is him, again, debanded. I think this is my last case to show in a 19-year-old female, again with a unilateral palate pair. Again, similar situation, class 3 malocclusion, missing her lateral incisor, this time on the left side. Her preoperative had an OPG. Lateral septum showing class 3 malocclusion. And the plan, again, was a Lefort advancement. I also decided to do, based on my analysis of her, to set her mandible back just a little bit as well. And we also took her wisdom teeth out. This is her intraoperatively at the end of the procedure. This is her films post-operatively. Now, the thing that I worry about with the VRO segments is that the condyle seated in the fossa. Sometimes you will see them kick out like this, and after a couple weeks of MMF, your mesenteric sling will bring that proximal segment. Great. So I wanted to spend the next few minutes talking about Invisalign orthognathic surgery, which is something that we've started doing more and more over the last couple of years in the States. So Invisalign orthognathic surgery, or clear aligner orthognathic surgery. It was developed for individuals who didn't want traditional braces, who wanted to have their teeth straightened, but using retainers, clear retainers, as opposed to conventional braces. And this is known as clear aligner, but more popularly known as Invisalign orthodontics. Invisalign is actually the company that promotes this sort of orthodontic treatment. And as such, more and more orthodontists are doing this technique more frequently and trying to incorporate that into orthognathic surgery patients. So there are some nuances when we talk about doing this type of procedure. So interestingly, Invisalign was actually first developed by a Pakistani American while he was a MBA student at Stanford. He was getting orthodontics, and I guess felt like there was a lot of pain associated with his orthodontic therapy. He had a background in biomedical engineering, so he and his colleagues developed the concept of Invisalign using retainers to move teeth, and he trialed this technique at the University of the Pacific in San Francisco before ultimately opening Invisalign technology or line technology. And it's really gained popularity over the last 20 years. It started very small, but now you have over 4 million patients using this style of orthodontic therapy. And in general, what happens is you have an orthodontist, preferably, but sometimes some general dentists do this procedure. They scan the dentition, they upload the scan to the company comes up with a treatment plan and provides aligners for the patient to wear over a set period of time. And slowly it starts moving teeth into an ideal class 1 occlusion. So some of the things that I've found with doing orthognathic surgery on an Invisalign patient is, one, you don't necessarily have ideal options for maxillomandibular fixation that you may require to stabilize and reposition your upper and lower jaw. And so we've had to come up with different ways to do this. Segmenting a maxilla and getting those segments to stay in the position that we want them to is also a challenge when you have somebody who has Invisalign. We have to develop different types of splints rather than the conventional orthognathic splints in Invisalign patients. And then the question becomes, when do you wear aligners post-orthognathic surgery? And some orthodontists want me to put aligners in right away, which is a challenge. Some people would prefer I wait for 2 months. So interestingly, there's very little in the literature about Invisalign orthognathic surgery, although I suspect over the next few years we're going to be seeing more and more discussion about this topic. Now, because you don't have braces, what are your options for MMF? There's a few. Put arch bars on, orthodontic buttons on, you can do MMF screws, hybrid MMF is something that is starting to gain popularity in the States. It's basically screw-retained arch bars as opposed to using wires. So that's an option. You could use MMF screws or tags, which is something I like to use as well for maxillary fixation. The only problem with this is your maxillary gingiva, the segmental case, your blood supply is through the gingiva, so you could have some potential compromise. The other thing that I like to have the orthodontist is place little buttons on the dentition, which will allow me to put patients to MMF. The rate limiting step is that these buttons are continuously applied and they can be easily popped up. So oftentimes I use a combination of these buttons with MMF screws as backup. Now, when it comes to splint design, we actually are designing splints in the form of what's known as tray splints. So these are much thicker splints that encompass not just the occlusal surface of the teeth, but they're also encompassing some of the facial, occlusal, or palatal surfaces of the tooth. So they snap in, snap out. And they add added stability, so when you're moving the maxilla and mandible around, you have a little bit more stability of the segments. And this is what the tray splints look like. And you can see from the bottom picture, I had a case with buttons, but I also used MMF screws to supplement to bring the patient to MMF. And then I have a tray split. And you can see how the split's designed to kind of fit around the teeth itself, not just the surface. So, I've done a few orthognathic cases. I think by now the numbers are a little more, probably about 50 cases. And the things that I've learned from doing this is, again, with MMF, using buttons plus MMF screws probably work really well. And honestly, doing sagittal splits instead of VROs actually work much better with Invisalign procedures. If you're going to do a segmental Lefort as well, you really need to have very rigid tray splits, so the splits don't bend, so that your segments of the maxilla stay in the position we want them to stay. So again, this is an example of my MF technique, which is using the buttons plus MF screws. Some cases. So again, this is the first case I ever did with Invisalign from 3 years ago, class 3 malocclusion. And again, at the time, we used a combination of ivy leaks and buttons. And then the orthodontist asked me to put the aligners in right away. The problem with that is you don't have an arch wire in, so the teeth were sort of going wherever they felt like going. So anteriorly, we had a little bit of intrusion of the anterior teeth, which, as a surgeon, sort of wasn't happy with. But eventually, the orthodontist was able to pull that in place. And this is him at the end of his treatment. Another case is a class 3 patient, class 3 knee bite, has perio issues, which is why the orthodontist elected for Invisalign as opposed to conventional braces. And again, same thing, Lefort osteotomy, osteotomy, got a good occlusion, use these buttons to place her into MMF, cut her out, and this is her end result. She ended up having a bone graft in the edentulous spot, and so that was early on, and again, I struggled with these buttons. So now I've switched to sort of a combination of MMF screws with the buttons, and they seem to work fairly well. Another case, class 3, was a little more challenging because she already had some implants in her. And again, you can see that okay result, but this particular orthodontist wanted the aligners in right away, and that opened up the bite, unfortunately, because of the aligners.
সব এগুলো কিন্তু বেশি পাহাড়ও দেন
So they opened up her bite a little bit. But she was able to eventually get a reasonable occlusion with a decent overgeneral. This is an anterior open bite case that was being treated with Invisalign. Again, she had before sagittal split osteotomy to treat her. And then this is her post-op CT scan. And because of the sagittal splits being rigidly fixated, we were allowed to mobilize her much quicker and get the aligners in her much quicker compared to the bureau. And this, I think, is the final case I wanted to show. Again, a 23-year-old male, severe class 3, a relative transverse discrepancy. Actually, when we put the models together, he didn't have transverse discrepancy. So he was going to have Lefort osteotomy and maybe a setback. I like using, in him, the orthodontist didn't have those buttons to apply to the dentition, so I used multiple MMF screws throughout both arches and locked them in to really get the occlusion required for almost 4 weeks, and then released them. Back to the orthodontist wearing aligners. He's still in progress. This is another case. I think this is the final case. I just wanted to show a complication where, again, class 3 malocclusion. We ended up using MMF screws, etc., to support her occlusion at the end of the surgery. And then once we started cutting her out of MMF and started putting the aligners in, her bite opened up. And we did a PRO in this case. So I think probably would have avoided this had we done sagittal splits. The PRO site was not rigidly fixated with a local plate. So she's still a work in progress. She's a recent case. Now, when we talk about segmental orthodontics, this is particularly challenging in Invisalign cases. The reason being is that tray split, as I came to learn, can be very, it's not rigid enough initially. And you really need to have a very rigid split, otherwise the segments may rotate in if the splint is original.
MBA করার
And
ইচ্ছা ছিল
that
আমার
will then affect your
গ্রাজুয়েশন করার পর চিন্তা করছিলাম MBAটা
So
করে
this is an example of
ঢাকা ইউনিভার্সিটিতে
a young man
করে
with class 3, but he also
Armed
had
Forces
a transverse issue with maxilla.
জানো
And our problem was that
টেকনোলজি
this
যেটা
intermediate split,
ওইখানে গিয়েও কাগজপত্র নিয়ে আসছিলাম তো করার জন্য
and so we had to replate him multiple times. So
এখন মনে হচ্ছে আমরা
it
যখন
took
গেছি তখন
about
ছিল
3 attempts
মিরপুরে
of
ক্যান্টনমেন্টে
plating to actually get the
Military
transverse
Institute of Technology.
discrepancy finally fixed.
এমএসটি হ্যাঁ
And
সায়েন্স
that's
সেন্টার
simply because the intermediate trace splint was not rigid enough.
এখনই না ইউনিভার্সিটি অফ প্রফেশনালস কোর্স আগে এটা ছিল ইউনিভার্সিটি অফ
This
প্রফেশনালস
was
পরে গেছে
operatively
ওটা আন্ডারে মনে ওগুলো দিয়ে দিচ্ছে
maxilla in his fort, and then sent them back to ortho. Again, this particular orthodontist has a split going very quickly, and so it opens up the bite a little bit. But this is him. He just sent me this picture
বিনোদ আগরওয়ালের কোন ভাই
weeks ago, and
সিঙ্গার ছিল
well.
নাকি
So
গিটার
what I we had another case. I did this case with Dr. Jacob.
ব্র্যান্ডেড কোন
This is
এক
somebody
গিটার
who
ছিল
really
ব্র্যান্ড
was
জানো
poorly planned
অবস্কিউর
by the orthodontist. The orthodontist just
লিড
kind of
গিটার
sent
ছিল
me
সুমন ভাই সুমন
in the middle of
সুমন তো আমাদের বোনের স্টুডেন্ট না
severe, significant transverse
অবস্কিউরের
discrepancy,
প্রোগ্রাম
10,
প্রোগ্রাম করতে
11
তার দিকে
millimeters.
থাকতে পারে
Should have had a surgically assisted
ওইটা
rapid
সে আবার
palate
এমবিএ
expansion
করে ঢাকা
from the
ইউনিভার্সিটি
get-go, but didn't. And the orthodontist was okay if we finished this case with a little bit of crossbreed in the back. But you know, we did it. Also, you'll note there's significant perio issues. So there's a lot of issues with this case from the get-go. So it was a fairly significant expansion. At the very back, it was over 10 millimeters, and that's a long way to go to expand.
বেসিক্যালি কি ওনা ইউনিভার্সিটি বেসিক্যালি
So what I had them do is design a very rigid intermediate splint
যে কোনো
with a large
Jessica
column
Lee
strap
trainer
to
for the
prevent
Louisiana.
the split from flexing.
সে এখন ক্রেনে অফিসিয়ালি ফেলোশিপ করতেছে
And again, use buttons and screws, but even then, it was hard to get this thing expanded.
কোরিয়ান হলো
We got it as much as we could, but the second molar was
কোরিয়ান
still
অরিজিন
across.
কোরিয়ান নাকি চাইনিজ অরিজিন
So again, that was a recent case. It's still a work in progress. I haven't seen the patient since I sent them back to the orthodontist. Now, the last thing I wanted to mention, and Greg had mentioned this a little earlier, I find that using custom plating, especially when you're using segmentalized maxillary Lefort osteotomies in Invisalign, makes life a lot easier. You don't have to depend necessarily on those potentially flexible trace holes. So as a result, you have a rigid custom-made plate that's putting that maxilla where you want it. So you're not dependent on trace holes. So I think this is a good option for Invisalign cases.
যদি অফিসের ফ্যাক্টরি আমরা বাংলাদেশে আনতে পারি তখন আমরা
The issue is with these custom Lefort plates, you get a marking guide that you have to follow closely because the predictive holes in these guides are basically where your rigid fixation custom plate is going to lie. So you have to follow those guides very, very closely. Okay, and so you get these occlusal-based lock guides, occlusal-based guides with these holes in it, and these holes are predictive holes for where your custom plate is going to go in. And this is just a picture of a cutting guide for interdental osteotomy.
গ্রাফিক মেশিন লাগবে এটা আমাদের আছে
And this is a three-piece Lefort, and this wasn't an Invisalign case, I'm using it as an example, but you know, these are the osteotomies for marking guides with our interdental cuts. And then we had holes made, you can sort of see from the guides. And then our custom plate went right into, or screwed into those holes. Theoretically, that will move the maxilla into the ideal position that we had planned for the surgery. So this is a great technique when you have Invisalign, because then you don't have to, I mean, if you don't need splints. This is splintless surgery when you have these custom plates.
ইনভিজিলাইন অ্যালাইনার ইনভিজিলাইন
So again,
দেখা
to
যাবে
conclude, I mean, I think
Clear to,
Invisalign
clear to,
is
মনে হবে যে কিছু
way
বড়
in
না।
the future. I suspect that in the
Transparent.
years to come, we'll be seeing that here in Dhaka as well. And you know, that's why I wanted to present this. You really need some good
সবার প্রেজেন্টেশন
rigid
রেকর্ড করছে
splints You really need to figure out your best way of doing MMF, buttons and MMF screws are the way I do it. And talking to the orthodontist, having a good conversation with the orthodontist. And sagittal splits probably are the best way to go for the mandible. And custom plating for the before Okay, thanks so much. This is me and Dr. Marchena 30 years ago at Harvard.
মারছেন না এই যে গোলটা মারছেন না